esophagus. What type of esophageal cancer would it be? Squamous cell carcinoma. It could be a squamous cell carcinoma. We have clues to this. We have alcoholism. Usually, this type of cancer is related to drinking, smoking, alcohol. And the thing we know about squamous cell carcinoma of the esophagus typically develops where?
First 2/3.
Proximal 2/3. Proximal 2/3 of the esophagus. There it is, middle of the esophagus. And it has, of course, ulcerative morphology. And we know it looks like a malignant ulcer. So, squamous cell carcinoma, that's what we're going to see on biopsy section. That's probably what it is. Take a look at these other answers. Adenocarcinoma. Adenocarcinoma is esophagus. Why wouldn't it be an adenocarcinoma of the esophagus? Distal 1/3. Wrong location. What else? What's the antecedent condition?
It's GERD.
GERDs. GERDs, yes. So this would be associated with distal 1/3 of the esophagus, and the antecedent condition would be gastroesophageal reflux. We don't seem to have a history of that. And the location. So, now it's adenocarcinoma. Okay, multinucleated cells with intranuclear inclusions. Probably this microbiology. Know what this might be? An infection. That can cause an esophagitis. Presents with ulcerations throughout the esophageal mucosa, very painful swallowing. The patient will be reporting dinophagia. Usually it develops in a person who's immunocompromised. Classic multinucleated giant cells with intranuclear inclusion bodies. HS. That's pretty simple stuff. This doesn't really develop in anyone except for people who are immunocompromised. So that's HSV, and then the virus causes the cells to fuse together, making multinucleated giant cells. The nuclei are often described as molding to each other. Nuclear molding. And we've got these basophilic inclusion bodies. That's HSV. Next, collagenous scar. In the esophagus, very often, mid-esophagus, proximal esophagus, usually associated with ingestion of something caustic, something that damages the esophagus, like someone drinks Drano, sodium hydroxide. Sometimes kids will get full of liquid Drano, and they think it's some sort of hot candy soda, and they drink it, and it burns the proximal esophagus, the scars everything down. That's very often why we see dense collagenous scar in this area of the esophagus. It's associated with ingestion of something like sodium hydroxide, something that burns in the esophagus. And thrombosed vascular channels, and in with that issue. I'm guessing we're referring to the esophageal varices. Esophageal varices. These are the submucosal veins that are very extended, convoluted. They can thrombose, especially if they start bleeding. We actually will go in, thrombose them. Maybe that's what they're requiring. But certainly, there's nothing here that would make me think about thrombose vascular. So there's our answers. So, any questions on this? things for esophageal cancer: antecedent conditions, location. This is very important. Approximately 2/3 of the esophagus, history of drinking and smoking, that's squamous cell carcinoma. Distal 1/3, history of GERDs, that's adenocarcinoma. Those are good generalities to remember. We talked about one notable exception, squamous cell carcinoma. Sometimes it can develop in the distal 1/3 of the esophagus because of this antecedent condition. The exception to the rules.
Was it Barrett? No, it wasn't Barrett's.
Close. Barrett's esophagus would be associated with GERDs.
GERDs, yeah.
Something that causes inflammation there. Achalasia, that's the exception. Achalasia, food gets caught in the distal esophagus because the LES won't relax. Imagine food is stagnant there, it incites inflammation. Achalasia and squamous cell carcinoma. That's the only exception that you need to know about for your boards. So we got the esophagus here, you got the stomach over here, there's the LES right there, the achalasia gets caught here. And so it's in the distal esophagus, and that's going to cause inflammation here, leading to dysplasia, and that can cause squamous cell carcinoma. There's some metaplastic change before that happens, dysplasia, squamous cell carcinoma. What does it say? What? Squamous cell achalasia. Okay. This one is up. Okay, anything else on this? No question. So, during summer, black and white days, week-long local community celebration of dairy industry. Holstein cows are black and white. A 40-year-old man has episodic abdominal bloating, flatulence, and explosive diarrhea. It's usually associated with lots of gas. On physical exam, there are no remarkable findings. Lab studies show that there's no increase in stool fat. So this is not steatorrhea. There's no cold blood. And trying to rule out infections, at least parasites, cysts, a routine stool culture with no pathogens. Okay, so they're trying to tell you whatever this is, it's not an infectious disease. During the rest of the patient does not consume milkshakes or ice cream and is not symptomatic. Okay, this is only associated apparently with the consumption of dairy products. Which of the following conditions best accounts for these findings?
Celiac?
And celiac, that is something associated with ingestion of
Gluten.
wheat, or specifically the protein gliadin. And this seems to be associated with dairy products. Disaccharidase deficiency. Which disaccharides? Lactase, right. Disaccharidase deficiency. ACE deficiency. That's disaccharidase. It's responsible for cleaving the disaccharide lactose into two monosaccharides, which are what? Glucose and galactose. So this one will cut glucose into cut lactose into glucose and galactose. Okay, so that's the right answer. This is called, of course, lactose intolerance. Lactose intolerance. Okay, that would be associated with ingestion of dairy products. Dairy products have the sugar lactose, that's saccharide. Without this enzyme, you can't break it down, so the sugar remains in the GI tract, and bacteria will thrive on it, producing gases, damaging the mucosa, causing malabsorption, and it should present with things like flatulence, explosive diarrhea.
Dr. Maddie. So if someone with a that's lactose intolerant, if they kept eating this stuff, even though it caused them issues, would that eventually result in like change in the epithelium? Or
So would you, what do you mean, would you get a metaplastic change, or would you
Yeah,
change
could
gene
that-
expression to increase lactase?
like metaplastic change?
This would more likely cause dysplasia
Yeah.
because of the inflammation. It's already a glandular type epithelium,
Mhm.
and presumably something like that would be irritating, would favor a glandular epithelium, mucous-secreting glandular type epithelium.
Mhm.
So this wouldn't result in metaplasia, but it would result in dysplasia.
Okay, and that couldn't turn into metaplasia?
It's kind of like we're skipping the metaplasia. We're already with the epithelium that can best deal with the conditions.
Yeah.
And so this would progress directly to dysplasia.
Mhm.
And there would probably be some sort of measurable increase in bowel cancers in these people.
Okay.
I don't know how big the difference would be, but. Okay, so that's the right answer. Celiac disease, again, also known as celiac sprue. It's also known as celiac sprue. This is associated with juxtapolism. Okay, and again, you'd have some of the same symptoms. You'd have some sort of malabsorption associated with wheat. Autoimmune gastritis. How would that present?
No parietal cells. It's like,
Right, so the autoimmune disease would wipe out the parietal cells, and as a result, you would have achlorhydria.
Yep.
What other findings would there, maybe some blood chemistries? Achlorhydria would be one. So we have G cells here,
Something that started with an A.
parietal cells up here. What did you say?
Something that started with an A.
Achlorhydria.
Oh,
When
okay.
you're thinking that?
Yeah.
Okay, so parietal cells are wiped out, right? Normally the G cells stimulate the parietal cells with gastrin.
is
And
it
that causes hydrochloric acid.
intrinsic
which
factor?
will inhibit the G cells. So what happens if I cut this negative feedback loop right there? What would happen to the gastrin? Increase. Hypergastrinemia will be another finding. And when we wipe out the parietal cells, we also stop producing something for the absorption of B12. Intrinsic factor, which is glycoprotein. So we could develop a B12 deficiency, and that would present as a pernicious anemia. So pernicious anemia, this particular anemia would have some odd RBC indices. It would be microcytic, macrocytic, macrocytic. So if we have a B12 deficiency resulting from failure to produce intrinsic factor, then we could potentially develop a macrocytic anemia. It's not a foregone conclusion, but it's possible. Macrocytic anemia due to the loss of intrinsic factor.
How did you say the intrinsic factor? How do you lose that through this?
Well, it's made by the parietal
Oh,
cells.
okay.
And the autoimmune gastritis would wipe out the parietal cells.
Mhm.
And without the parietal cells, there's no HCl, there's no intrinsic factor.
Yeah.
Okay, intrinsic factor would lead to. So that's explicit. No intrinsic factor would result in a decrease in B12 absorption, and that would lead potentially to macrocytic anemia. It's also sometimes called pernicious anemia. Pernicious just means harmful. And we could easily correct that. We could just give a B12 supplement. Well, it's not totally harmless, but usually you can get away with giving a lot of B12 without any problems. Even without intrinsic factor, you can still absorb 1 or 2% of B12. Okay.
Does sublingual B12, does that bypass the B12? Sublingual B12?
Sublingual B12, we've tried that. There's really not much of a difference between sublingual B12 and just typical PO. B12 orally.
So they both need intrinsic factor
For absorption, well, it'd be more efficient if you had intrinsic factor. You can absorb a significant percentage of B12 with intrinsic factor. However, the way we treat this, someone didn't have intrinsic factor, they'll be absorbing only about 1 or 2% of B12, so we just give them a lot of B12. As long as they're absorbing the 2% of B12, we can adjust the dose of that recommended allowance. We did try a study with, actually we conducted it here. We did try a study with oral B12 versus sublingual B12. As long as we were using, saturating doses of B12, there was no difference in the amount of B12 the body was absorbed. The body got plenty of B12.
What about like not saturated levels? Is there a difference there?
Suboptimal levels, yes. If you have lower levels of B12, then you basically rely on intrinsic factor to increase the efficiency of absorption. So if you're not absorbing a lot of, if you're not ingesting a lot of B12, you're going to need intrinsic factors there for a purpose. Not just a lot of B12. Well, you're going to need that extra efficiency again. Absorb. Yes.
Do B12 injections help with that?
We used to do B12 injections. It's really not essential because there's just so much. There's still 2% of the B12 that can be absorbed, so you just give them a really big dose of oral B12, and that's just as fine. Just as good. Anything else? Okay. So it's not autoimmune disease. How about cystic fibrosis?
Delta 508.
Delta
F.
F508.
So yeah, that's a common mutation.
Chromosome
7. That was not
Okay,
one of
so
the questions.
cystic fibrosis, genetic disease affecting what gene?
Where
is that Delta F508?
Valine, the glutamine.
Oh.
CFTR gene.
Oh,
Yeah, so this is a genetic defect. CFTR
yeah.
gene.
You can do all about that.
Okay, and what is the gene code for?
Chloride channel.
It codes for a chloride channel.
In
So it's also known
anion
as the
chloride.
CFTR protein.
I know all this
It's-
now.
And it closes it.
I know this
Not
now.
opens it.
Yes, and that is an anion channel. And that mostly is responsible for conducting chloride, which is an anion. And you're absolutely right. The mutation keeps it closed.
Yeah.
Not open. Okay, so what would cystic fibrosis present?
With a bunch of salty babies.
Salty baby, yes, at birth would probably be diagnosed. How old is this guy? 40?
Yeah, he's salty.
He's
That's
a
why he's so
salty
angry
guy.
all the time.
It probably would have been diagnosed a little earlier than 40. Probably at birth. What other symptoms? Cystic people with CF do
They have the
develop
mucus.
malabsorption syndrome. Malabsorption syndrome be due to what?
Pancreatic.
Pancreatic insufficiency. So this would lead to pancreatic insufficiency. Insufficiency. And without the pancreas producing exocrine digestive enzymes, you're going to develop a malabsorption syndrome. And malabsorption syndrome, of course, will present with diarrhea. What kind of diarrhea? Best kind.
This is the best kind.
Best. Okay.
Describe that for me.
I'd have to go along with that. Can you give me a clue as to what might be unusual about the best kind of diarrhea? What makes it so good? It has a nasty smell to it, and why is that? Diarrhea. Diarrhea, it's got a lot of fat in the stool. That's what makes it so-called foul smelling. A more important determinant of whether fat is present in the stool or not would be whether the stool floats or sinks. Most stool will sink because it's got a higher density. When you put fat in, fat's not so dense, so the stool will float. So if there's a significant amount of fat in the stool, it'll float. It's diarrhea. Okay, well,
It'll also be streaky.
What?
It'll also be streaky.
Wait, so the diarrhea would be floating.
The more you know.
all right, so anyway,
I don't
there's a
see
lot
that.
that
I have
goes into
cystic fibrosis.
The person would have a history of a lot of respiratory infections. It wouldn't present late, and we're
Did you ever see the machine they wear?
here. No
Jordan,
increase.
Did you ever see the machine they wear?
So that's not
It's a
diarrhea.
fibrosis machine. It's fucking.
And cholelithiasis.
It's a big vest.
Cholelithiasis.
It's fine.
Cholelithiasis. Anybody know what that is?
Break up the mucus.
Gallstones.
Look it up. I looked up on YouTube. Fucking wild.
We're going to talk about this one. And how gallstones present. If it's blocking the ampulla, it could present with malabsorption. No bile will be entering the GI tract. That helps absorb fats, to break down fats. Maybe it'll also obstruct the pancreatic outlet, so you're not getting pancreatic enzymes in there. What are the symptoms? We know the classic symptoms for gallstones. Right upper column pain. Right upper quadrant column pain. Every time the gallbladder contracts to expel bile, it's contracting against mechanical obstruction. That hurts. And so you get this right upper quadrant column pain.
Wait.
It's on the from the wrong part. So
Okay, any questions about this one? Analyze this depth.
More analysis, please.
Don't forget.
Already done
Cystic
that.
fibrosis. The best diet.
So I remember.
No,
Number 13. We have a 68-year-old woman has substernal pain after meals for many years. Substernal pain, many years.
It's chronic.
For the past year, she has increased
Very good.
difficulty swallowing. So again, we have progressive dysphagia. This is to both liquids and solids. That's not a good sign.
Cancer.
Physical exam, no remarkable findings. Upper GI endoscopy shows a lower esophageal mass that nearly includes the esophagus.
Yeah.
Lower esophageal mass, so presumably that's going to be in the distal 1/3 of the esophagus. A biopsy specimen of this mass is most likely to show which of the following neoplasms. Okay, so we got a mass in the lower esophagus, assume that's distal 1/3. Substernal pain after meals for many years. What are the possibilities? GERDs, that's one. Anything else? Maybe this GERDs. Should be something else. Substernal pain after meals and difficulty swallowing. It could be achalasia, okay? What about this substernal pain? GERDs, maybe achalasia. Anything else you want to put in here? How about peptic ulcer disease? Could it be an ulcer? Eat some food, pain goes away, then maybe 1 or 2 hours postprandial after eating, pain's back again. It says substernal pain after meals for many years. Possible. Okay, well. What are we gonna do? Biopsy specimen of this mass is most likely to show which of the following neoplasms.
I don't know.
Okay. That would be my first impression, maybe an adenocarcinoma. This
However,
is indeed GERDs. It's an adenocarcinoma. It's in the right place, right antecedent condition. But someone mentioned, could this be achalasia? And if it's achalasia, it would be in the distal 1/3. It would have to be a squamous cell carcinoma. So how do we figure this out?
this goes in.
If this were achalasia,
Wouldn't
they'd be laying down.
isn't achalasia would it go on for that many years? They
for
could.
many years, achalasia would probably, at the age of 68, would have presented with some sort of maybe progressive dysphagia. Perhaps they would regurgitate some food, if they lie down, it'll roll up. Lower esophageal mass, really includes the lumen. Okay. 68 is a kind of an older age to develop achalasia. Trying to figure out how to rule out achalasia.
But what if they give you more information?
They probably have to tell us a little more.
So quick.
Now, here's a trick to use on not only boards, but real life. Which is more common, GERDs or achalasia?
GERDs.
Okay, so if nothing else, I would go with first, simply because it's so common. Achalasia is not all that common. Okay, so I think the author of this question wants us to think this is GERD, plus is something else. It says the pain after the meal. With achalasia, you'd feel discomfort and pain before the meal, during the meal, and after the meal. It wouldn't be just after. Okay. That's kind of tricky. We considered achalasia. It's a good thought. All right. So what's the answer? This is GERD's. Adenocarcinoma. Okay, right location. Distal esophagus, they don't tell us where. This is lower esophagus, distal esophagus. Okay, GERD's is the right antecedent condition. Looks like that's the right answer. Leiomyosarcoma, what is that?
That's in the cervix or uterus? Cervix,
You're
uterus?
thinking of maybe fibroids, which are leiomyomas, and leiomyosarcomas can develop in the uterus. There's just general malignant proliferation of smooth muscle. Malignant proliferation of smooth muscle. This could develop in the esophagus, but again, these are kind of bulky masses. They don't necessarily develop in the distal one-third of the esophagus. They don't develop in association with GERDs. Adenocarcinoma in this case would be much more likely than leiomyosarcoma. So this is a malignant proliferation. Smooth muscle cells. That's the leiomyosarcoma. Squamous cell carcinoma doesn't fit here, unless we're thinking achalasia. Wrong location, wrong condition. Some sort of lymphoma. Lymphomas can present with masses. Usually, though, lymphomas will present with adenopathies first. The cervical lymph nodes will be involved. Inguinal lymph nodes will be involved. That's typically how these lymphomas present. Very, very large lymph nodes. They present with a mass in the esophagus, but again, how common is that compared to, say, adenocarcinoma caused by GERDs? We've got antecedent conditions. Why would I think a lymphoma when I have all of the antecedent conditions that are consistent with adenocarcinoma? And a carcinoid tumor, you mentioned that one before. What's a carcinoid? Where does that one usually develop? That one usually develops in the airways. And sometimes it's associated with carcinoid syndrome. What's carcinoid syndrome? Carcinoid syndrome is caused by excessive serotonin and bradykinin. It's a condition where this tumor elaborates a lot of bradykinin, a lot of serotonin, causes airway restrictions, wheezing, flushing of the face, diarrhea. That's called carcinoid syndrome. Carcinoid syndrome. That's due to increased serotonin plus increased bradykinin. Again, no symptoms like that. This is something usually found in the airways, not the esophagus. Again, what about all these others? Could you have known about these? Well, again, we're going to go for the most probable thing. Antecedent condition, location, all of that is consistent with that, of course. Okay, any questions on this one? Yeah, if this were achalasia, and I would have to be pretty obvious about this being achalasia. then the answer would be squamous cell carcinoma. That's the exception to the rule. I would probably say, this person has achalasia. I couldn't be this ambiguous. I mean, if that were the right answer that the author expected, then the author is being unfair. Yeah, pretty obvious. Okay, anything on this one? Thirty-year-old man has sudden onset of hematemesis after a weekend in which he consumed large amounts of alcohol. Hematemesis and alcohol. So, there are two things I can think of immediately connecting those two.
I said a good time.
A good time. So, hematemesis and alcohol. So, one would be related to liver disease. Would be related to cirrhosis, so. So maybe liver cirrhosis, portal venous hypertension, which can cause varices, esophageal varices. So there's a link. How about one other one? Alcohol and hematemesis. Differential diagnosis. Acute gastritis. Those are two that could potentially explain this. Maybe one of them's right, maybe we're completely off. Let's see. The bleeding stops, but he has another episode under circumstances 1 month later. Similar circumstances 1 month later. Upper GI endoscopy shows longitudinal tears. Oh, there's another. And longitudinal tears in the esophageal gastric junction. What is the most likely mechanism to cause this hematemesis? So, there's actually another possibility here. Tears. How about this? Overlooked. Longitudinal tears. So these are tears that develop as a result of deranged vomiting reflex. Person drinks alcohol. Throw up. Normally, the lower esophageal sphincter is supposed to relax, the stomach is supposed to contract, chyme is ejected, but in alcoholism, that reflex is deranged. The lower esophageal sphincter doesn't relax, but the stomach still contracts violently. It'll contract against mechanical obstruction that will cause the distal esophagus and proximal stomach to overdistend and tear. Those are called Malloy-Weiss tears. And what is the most likely mechanism to cause the hematemesis? The vomiting itself. Yeah. So, my guess. Absent planetary ganglia. What would that cause? The esophagus.
That would-
absent
That would weaken the, yeah.
So the esophagus would be aperistolic, and what would the LES?
The LES to be weakened or not
Would be-
functioning.
The mesenteric plexus actually confers inhibition. So you take away the inhibition, the esophagus would constrict harder. This results in achalasia. That's achalasia. Auto- We're considering the absence of myenteric ganglia. No myenteric ganglia that would present with achalasia. The LAS would be very tightly constricted, and the esophagus would be aperistaltic. Autoimmune inflammation. Like, I don't know, autoimmune gastritis, autoimmune esophagitis. Again, that's kind of odd, given the history we have, possibilities that we have. Hematemesis, I don't think we have to like come up with some other explanation that doesn't fit the circumstances we have. Autoimmune inflammation, and I'm not quite sure what type of autoimmune inflammation the author has in mind, but I wouldn't consider this being autoimmune at all. Herpes, esophagitis would present with an awful lot of pain. Person swallows, they've got dinophagia. Dinophagia. And they'd also would have to be some sort of immunosuppressant, some sort of immunosuppression. Okay, portal hypertension, that would go with our esophageal varices. Why isn't that the right answer? Because we're told there are longitudinal tears. And again, I don't have to leap into some sort of hypothetical situation. I'm being told that there are longitudinal tears in the esophagus. Those things bleed. Why should I think of anything else? Maybe there could be something else, but I have to choose just one of these. Portal hypertension would cause esophageal varices. Esophageal varices can rupture. But again, endoscopy doesn't mention any dilated submucosal veins. That would be esophageal varices. And again, I just can't overlook the longitudinal tears. So why would I take this? Even though it could be a potential differential that causes hematemesis. Why in diaphragmatic pleura? How is that even relevant? How does this present? How about that? Hiatal herniation, the crura, flexion from diaphragm, that keep that little foramen tight around the esophagus. The esophagus goes from the thoracic cavity to the peritoneal cavity. It's got to go through the diaphragm. It goes through the esophageal hiatus. And if the crura are loose, the stomach can herniate from the peritoneal cavity into the thoracic cavity. It's called a hiatal herniation.
Is the LES distal, proximal, or right in the middle of that foramen?
The
Usually.
LES is
We
kind of
just passed it.
spans the distal esophagus and proximal stomach. So part of the LES would be just distal, maybe right on top
Yeah.
of the hiatus. Okay. Again, widened diaphragmatic curve would cause hiatal herniation. What would that present with? It would probably be of what type? Axial or rolling? It's probably axial because 95% of them are axial. That would present with regurgitation, epigastric pain. It would have no association with alcoholism. It wouldn't cause longitudinal tears. So again, I mean, what's the connection? There is none. Okay. Questions on this one? So this is calorie-wise tear. Okay, why don't we take a break?
They have like close argument.
Okay. A 7-year-old man takes large quantities of non-steroidal anti-inflammatory drugs with chronic degenerative arthritis of the hips and knees. So he's taken a lot of these NSAIDs. And recently, he has had epigastric pain, nausea, vomiting, and hematemesis. Physical exam, there are no remarkable findings. The gastric biopsy specimen is most likely to show colon. So again, so we have no history of alcoholism, but we do have a history of NSAIDs. So NSAIDs can cause bleeding, epigastric pain, nausea, vomiting, episodes of hematemesis. So again, you got to think about a differential. What could be causing this? Ulcers. Ulcers, yeah, peptic ulcers, peptic ulcers. Disease. That's one possibility. How about something else? Something associated with aspirin. This is another one that can cause acute gastritis, which causes bleeding. Okay. So nausea, vomiting, epigastric pain, hematemesis. So they do a gastric biopsy, and the specimen's most likely going to be remarkable profile. Okay, well, one of our differentials is actually on here. Acute gastritis. Okay, so I'm inclined to think that's it. I don't see anything else that could fit. Peptic ulcer disease is not listed. So that looks like the right answer. Epithelial dysplasia. That could be more associated with chronic gastritis. That's what you can think of here. And that would not present with bleeding. It would not present with pain. That's usually some sort of chronic process, indolent. I don't think that would present. Hyperplastic polyp, again, that's associated with what?
Gastritis.
Again, another one associated with chronic gastritis. That's not going to present with bleeding. Chronic gastritis does not generally present with any symptoms at all. It's an indolent process. It can cause hyperplastic polyps to develop because of epithelial dysplasia. Adenocarcinoma. Okay, I'm not sure what type of adenocarcinoma, whether it's esophageal or gastric. They're biopsying the stomach, so presumably they're implying gastric adenocarcinoma. Okay, gastric adenocarcinoma would be associated with what? And there are many types of adenocarcinomas in the stomach. There's the intestinal variant and there's the diffuse variant. Which one's associated with chronic gastritis? Intestinal. So, again, this could be associated with chronic gastritis. That would result in intestinal variant. Of gastric cancer. Again, there's no reason to suspect he's got chronic gastritis. He'll come back to pylori infection. Most likely acute or chronic gastritis.
I thought it was acute. It's chronic.
Some people believe it could cause acute, but that's never been demonstrated. Okay, chronic gastritis, and that could lead to maybe some patchy atrophy of stomach mucosa. chronic gastritis. Again, that's kind of an indolent process, not present with vomiting up blood. Acute gastritis, very symptomatic, nausea, vomiting, coughing up, vomiting up blood. The inflammation erodes through the mucosa, the vascular layers of the stomach, bleeds into the lumen, and you throw that up. So this would be acute gastritis. It was definitely one thing that was on our differential. Peptic ulcers do also bleed. Maybe you have a gastropeptic ulcer. It would present with epigastric pain. Use of NSAIDs would make the whole thing worse. And so that was a good thing to consider in a differential, but it's not a choice.
If it was a choice, would you be able to rule that out based on the information given, or does it always lead straight to acute gastritis?
I would hope they'd have something related to pain as a function of eating. That might give me a clue. But otherwise, I really could not rule that out. There was acute gastritis and gastric ulcerative disease. I would probably choose acute gastritis, but the only reason would be that NSAIDs are commonly associated with acute gastritis, but there would really be no rationale to distinguish between the two. Peptic ulcerative disease could cause bleeding. And NSAIDs could make it worse. Acute gastritis could also cause bleeding. Now, the blood that's coming up is probably not whole blood. It's probably more like pink fluid. As the blood mixes in with the gastric juice, and probably the person would be vomiting up pink fluid as opposed to whole blood that you might see, say, with esophageal varices rupture. Yes.
Does the H. pylori type of chronic gastritis, is that the only one that results in iron deficiency, or can like any of the chronic gastritis result in that?
Iron deficiency, Helicobacter pylori infection, iron deficiency, is really meaning some sort of acute blood loss, iron deficiency.
Yeah, I think in your notes, that's what I had down.
The bleeding is chronic, as in, for example, more likely peptic ulcer disease.
Oh, okay, yeah.
That can lead to an iron deficiency.
So H. pylori can cause
H. pylori can colonize an
colonize the
ulcer.
peptic ulcer.
Yeah, it could
Okay.
cause an ulcer to persist. Usually when you treat H. pylori with metronidazole, you eliminate the infection, the ulcer will heal. Some other ulcers are stubborn, they recur despite the fact that you treat them. That's an exception. In those cases, you might have to perform some surgery. You go back and forth with a vagotomy, you cut the biggest nerve. Whether that's appropriate or not, I mean, it's always debated. Okay, any questions on this? A 44-year-old woman has had increasing difficulty swallowing liquids and solids for 6 months. Okay, so again, we got progressive dysphagia on physical exam for, oh, okay, this one we want to skip. So, all right.
We did that.
I can do that. 35-year-old man has had epigastric pain for more than 1 year. Pain tends to occur 2 to 3 hours after a meal. It's relieved when he takes antacids or eats more food. We got postprandial pain that's relieved with more eating or antacids. He has noticed a 4 kilogram weight gain. He's gained 8 pounds in the past year. He does not smoke and drinks 1 glass of, that's what, whiskey
Riesling's a wine.
Drinking alcohol, 1 glass of all wine. The result of a urea breath test is positive. The gastric biopsy specimen contains urease. Begins a 2-week course of antibiotics, but on day 4 feels better. Discontinues treatment. How often is that? Several weeks later, the epigastric pain recurs. If the patient does not seek further treatment, which of the following complications is most likely to develop? Okay, so let's go through this. I want the differential diagnosis. We've got a couple of clues. Epigastric pain, postprandial, relieved with antacids and food. Okay. Gaining weight. Here's important things. Urea breath test is positive, and there is urease on biopsy. And somehow they thought it was infectious. They were treating it with antibiotics. So what's going on? That is probably an H. pylori infection that they're treating. Okay, it could very well be H. pylori. Where's the epigastric pain coming from? And the pain is relieved by eating. What's that sound like? Relieved by eating. About 2 to 3 hours later. Well, one of the things could be GERDs. Could it neutralize the acid in the stomach, the reflux won't hurt so much? Maybe.
GERD doesn't, it feels better when you eat, when you have GERD?
GERDs is caused by acid irritating the distal esophagus.
Mhm.
The esophagus goes through a spasm when it's bombarded by that acid. So presumably, if you eat to neutralize the acid, it should make it get better. If you have heartburn, which is GERDs, you take what for heart?
Okay, lots of times.
Lots of antacids. So could it be GERDs? I'm just throwing it out there. I'm not saying this is GERDs. Just what else? I actually don't think this is GERDs. But it could explain some of the symptoms.
Could you rule out achalasia based on the duration of when the pain is? Because you said earlier it's like it would be before, during, after.
They did, they did a biopsy, so to take that biopsy, they would have had to do an endoscopy. They should have seen.
They would have
something.
seen, yeah. Okay.
Yeah. They might have even seen something that GERDs may or may not. H. pylori, epigastric pain. The pain is not caused by H. pylori itself. What else is H. pylori associated with? Just talk. Ulcer.
Yeah.
That should be a big ulcer. Okay, so we got a working differential. We know we have H. pylori because of the tests. We're going to assume that's solid evidence for H. pylori. GERDs, not so sure about septic culture disease. That would be associated with H. pylori. Connect these two. H. pylori will colonize a peptic ulcer, perpetuating the ulcer. Apparently, they were treating this H. pylori infection. It actually got better when they was taking the antibiotic, and he stopped taking the antibiotic. Just based on that, could we eliminate GERDs, which is more favorable? GERDs or peptic ulcer?
Peptic ulcer.
I would be working with these two right here. This one and this one. I'd be less likely to suspect GERDs. Okay, let's assume it's a peptic ulcer. Several weeks later, the epigastric pain recurs. If the patient does not seek further treatment, which of the following complications is most likely to develop? So, we're working with the idea this is a peptic ulcer colonized by H. pylori.
Would it destroy or like go down into and like hit the blood vessels?
It can cause, yeah, it can erode into different blood vessels. Gastroduodenal artery is a common one.
So then it would
So it'd be hematemesis.
yeah, bleeding.
Cause bleeding, so hematemesis, that would be likely, that would definitely be likely. Could it cause fat malabsorption?
I don't know how.
Yeah, you could make a reach for that one.
Let me hear your reach.
Well, if for some reason this guy were making an awful lot of acid in his stomach, that acid gets into the duodenum, plus duodenal ulcer. It can also, that acid can also denature some of the pancreatic enzymes.
Yeah, it's far-fetched.
Yeah, totally know what you mean, man.
Okay, well, let's keep it there. How about this one, hepatic metastases? We're talking about a cancer somewhere?
No.
No.
Now we're really going for it. Carcinoid syndrome. You have diarrhea, you have a flushed face, wheezing. No. Carcinoid syndrome, right there. Right there.
Fernando, you see it?
I know, but it's not. supposed
Take
to
a
be like
picture.
that.
Why is it not on our
I
chat?
don't know. This is cancer on the.
This is part of our information.
Why don't you take a picture?
B12 deficiency. Could it cause, does a peptic ulcer cause B12 deficiency? No. You got parietal cells, making intrinsic factors. Part of what's perpetuating the peptic ulcer is the acid. Okay. He already has epigastric pain, peptic ulcer disease is most likely what we have here, colonized by H. pylori. Okay. If I had to choose between something that's very likely, peptic ulcer is going to bleed, this would have to be the result of a lot of acid being produced. We don't know that's happening. So given the choice between the two, I would say hematemesis. I think you're right. That was far. What possible? Any questions on this one? Okay, this is kind of a difficult one. I would not give you something this difficult.
You could just give us this
You say
exact
that.
question.
I could give you this exact question, which case would be
We'll take it.
Everybody likes softball.
I have done that from time to time.
You have, yeah.
I've given like verbatim
I know.
on the exam, verbatim.
Everybody likes a meatball down the middle of the plate every now
Yeah,
and again.
exactly.
You know?
Gotta get a home run every
So
once
if
in a
you're
while.
like, following along, I mean, oh yeah. Okay, any questions on this? So here's the summary. You clearly got indications of a peptic ulcer. The reason I would say that is because you got the epigastric pain, you got the postprandial pain, you have the urease pressure. H. pylori produces this enzyme urease. And so when you have urease in the stomach, you can assume that you got H. pylori. So what H. pylori do? It causes chronic gastritis, causes peptic ulcer disease, does not cause GERDs. Peptic ulcers are known to bleed, and that for sure is going to cause cilantro. So I wouldn't go for a stretch. I'd go for, what's pretty obvious. Okay, questions on this one? Okay, 27-year-old man has sudden onset of marked abdominal pain. Okay, notice the age, 27. Abdominal pain, that can be anything. On physical exam, his abdomen is diffusely tender and distended. Bowel sounds are absent. These are all linked. So he looks like he has some sort of paralyzed bowel caused by mechanical obstruction, functional obstruction. Gases are building up, extended. The abdomen is diffusely tender. He undergoes surgery and a 27-centimeter segment of terminal ileum. Terminal ileum. Firm erythematous dorsal surface is removed. So they removed part of the terminal ileum. Well, they would not do that for a functional obstruction. Terminal ileum suddenly develops in 27-year-old. It's very firm, it's inflamed, and removed. The microscopic appearance of section for the excised filling is shown in the figure. If on additional complications, this patient most likely to develop as a result of this disease. Okay. There's the figure. What are we saying there?
You see gastric
Bowel.
atrophy. No.
Here's the lumen. Presumably, this is terminal ileum, right? That's ileum. There's the lumen. What's wrong with it?
Sucks. This guy, the shitty ileum disease. I said shitty ileum disease.
Well.
Don't quote me on that.
Big thing here. Okay, so he's a young guy. Look at this ileum. It's inflamed.
It's got
You got
Crohn's.
this big, deep ulceration here. It goes down the muscular throat.
Big clue. Big clue.
Big clue. Young. Inflamed terminal ileum with a defect that extends all the way down the muscular throat. Crohn's disease. That's Crohn's. Yeah. Crohn's disease is also known as what? Terminal ileitis. Terminal ileitis.
Would the removal of the terminal ileum cure the Crohn's in this scenario?
We would be removing the affected segment of bowel, but the condition can affect other parts of the bowel.
Okay.
It's a systemic disease, even though we call it a bowel disease, inflammatory bowel disease, it really affects all the tissues. So it can have other manifestations. So look what we got here. Young person, that's when it often presents. Terminal ileum, inflamed, removed, got transmural inflammation, resulting in a very deep fissuring ulcer. Bowels paralyzed because of it. Which of the following additional complications is the patient most likely to develop as a result of this disease process? Percutaneous fistulas. Fistulas kind of characterize Crohn's disease. This is caused by transmural inflammation. Eat a hole right through the wall of the bowel. Did you develop an adenocarcinoma from this? Yes. it's likely that, or at least more likely, the person with inflammatory bowel disease can develop bowel cancer. But again, we are jumping ahead. This is most likely going to occur first. It may be after many years, persons in their 40s, they might be likely to develop that. But I would think that immediate consequence. Some artery in the mesentery thrombosis, that could cause a transmural infarction of the bowel. For that to happen, we have to recognize some sort of antecedent condition, maybe atrial fib, maybe they draw a thrombus that get caught in the artery. The heart, to the artery, lodges in the artery, blocks the artery, you get a transmural infection. The pain would be just out of proportion to any physical findings, and it'd be peculiar if it just happened to affect the terminal ileum in a young person. That's an awful big coincidence. A tussoception, what's a tussoception? So it's
It's when the bowel moves proximal to distal.
right, proximal and distal. Okay, there'd be acute onset of pain. Okay, but you would not see that kind of fistula formation. Bowel probably just infarct. You can see a fistula formation. And again, isn't it a coincidence that the terminal ileum would be affected? Now, hepatic abscess. What's going to cause the hepatic abscess? Maybe if it had a bowel infection, some sort of infectious agent, amoebic enteritis cause that. Evas probably cause hepatic abscesses in respect to bowel. Evoid dysentery is a type of diarrhea that contains blood and mucus. And there should be some history of dysentery. There's no history of dysentery. Okay. Anything here? No, these questions can be exhausted.
I think this is great. Well,
All righty then.
Well, what if I told you?
it's exhausting knowing all the answers.
I'll give you a real question. I'll give you one. Something important. You have a man who presents with a macrocytic. You perform some tests and you discover that his gastric fluid is remarkable for achlorhydria. And you discover he has hypergastronemia. What's diagnosis?
Gastritis? Wait,
Hypergastritis.
hypergastritis.
Yeah, that's a question I give you.
Wait, and he's remarkable for achlorhydria and
Let's say this. He's got macrocytic anemia. Got achlorhydria.
hypergastritis.
He has hypergastrinemia.
That was
Most likely diagnosis.
Do they have an
Let's
autoimmune
see.
disease?
Autoimmune, that's autoimmune gastritis.
Type, is there a different type? That's type B, right? No, type A, duh. Oh, A, duh.
And it fits, right? Achlorhydria, no acid, because all the primal cells are wiped out by the immune system. Because no acid, the G cells are disinhibited, that causes cytokine and an additional side effect might be a loss of intrinsic factors, so maybe he's now B12 deficient. Everything fits in there. That would be something.
So the G cells are what?
The G cells are disinhibited.
G cells.
They're the ones that make gas. Wipe out the parietal cells. The G cells are disinhibited. They're still there. But they're no longer inhibited by acid.
So they just take
That
over,
one-
right?
So that causes the gastrin to increase, right?
Yes, remember that diagram we showed?
Yeah.
We got the stomach. Okay.
It's
The
increasing
G cells are
gastrin.
here. The parietal cells are over here. Okay, G cells vibrate gastrin. That inhibit the G cells, they vibrate gastrin, stimulate the parietal cells, produce hydrochloric acid. That hydrochloric acid, G cells are producing more gastrin. Okay, so if you cut this feedback loop, there's no hydrochloric acid that disinhibits the G cells, high levels of gastrin, no acid, high levels of gastrin, you're not making intrinsic factor. The only one that we studied that causes that is autoimmune gastritis.
Where's the intrinsic factor like cut? Like where's that cut in this feedback loop?
The intrinsic factor is made by the parietal cells.
Okay.
you just described.
Okay, yeah. He wasn't paying
Word for word.
Now, that is a question I'd give you on the
attention.
because it's pretty straightforward, you know.
Yeah.
Once you study it, it'll be pretty straightforward.
Can you give us another example?
Did I?
It's one that's like really, really hard.
Really, really hard.
Yeah.
But also something we would see on the test. Shut the fuck up, Jordan.
Oh,
Well, obviously.
I gotta change my question.
Yeah. Yeah, sit down.
Think about this for a second.
Put your feet up, get comfortable.
Try to stump us.
But also lead us in the right direction.
Yeah. And make sure. it's on
Make
the
sure
test.
it's on- you know, just give us a test. Let's look at this.
Okay. All right, so you have a 56-year-old man with a history of alcoholism.
56.
And he's been diagnosed with liver cirrhosis. He presents to the emergency room, vomiting up whole blood.
Pharisees.
Yep.
Let him finish.
Well, was, I couldn't hear.
He presents the ER vomiting whole blood.
Vomiting whole blood. Okay, he's got dilated periumbilical veins. He's got hemorrhoids. What's the most likely cause of the hematemesis? All of those are connected, right? So you've got indications of portal hypertension already, the dilated periumbilical veins, the hemorrhoids. He's vomiting up whole blood, not pink fluid.
Esophageal
And
varices.
he's got a history of cirrhosis, which has caused the portal hypertension.
Is that the only one that was a whole blood? Or were there other ones that?
It's more likely that he's vomiting up whole blood. I mean, if you got a really bad bleeding peptic ulcer, it could present with whole blood. Acute gastritis more likely to present with pink So these are all like conditional probabilities. There's no absolute. Okay, so that wasn't too bad. No, okay, so that would be a classic question. Okay, so 59-year-old man is
Cause of,
swallowing during the past
hematemesis.
6 months. No
I'm gonna
significant
post this
findings
recording
on
to the
physical
YouTube.
exam. Upper GI shows areas of erythema above the Z line.
Wait, where we at? Where we at?
Swallowing
59.
6 months, areas of erythema above the mucosal line. A biopsy from the lower esophagus, microscopic expansion, and a big. Which of the following complications is most likely to occur?
Where's this question?
Okay,
Oh, there it is.
that's
Okay.
supposed to be the esophagus. That's the distal esophagus. So someone come up here and tell me what's. what are we
Oh.
seeing? Lots of glands. Lots of glands, okay? There's supposed to be lots of glands in the esophagus? No. What am I supposed to see in the esophagus? The mucosa of the esophagus. I'm not supposed to see glands. I'm supposed to see a squamous cell, basically a squamous cell epithelium, a stratified squamous epithelium. I'm not seeing that. Here is the epithelium. And here is the lamina propria. I'm seeing a glandular epithelium, columnar cells with goblet cells. What do I call this? It's not supposed to be here. It's supposed to be squamous epithelium, but it's been replaced with a mucus secreting columnar epithelium. We got 3 names for this thing. Barrett's esophagus. That's Barrett's. Barrett's esophagus. Give me another name for it. Intestinal metaplasia. Give me another name. How about columnar metaplasia? Okay. I think we got the diagnosis. This is Barrett's esophagus. So they're asking us, which of the following complications could occur as a result? Metaplasia doesn't bleed. So I think we can cross out hematemesis. How about squamous cell carcinoma? That's in the upper esophagus, and this is not caused by GERDs. Barrett's esophagus is caused by GERDs, right?
Right.
GERDs
Yep.
cause
Antecedent.
metaplastic change. Let's write this down. Main problem is GERDs. Leads to metaplasia. Right, possibly dysplasia. And then adeno. Not squamous cell carcinoma. You say adenocarcinoma is the right answer? Okay, we'll tentatively say adenocarcinoma. Could it cause achalasia? No. Achalasia is caused by deterioration of the myocardial plexus. Lacerations, that's caused by vomiting. I have a history of vomiting. It's usually associated with alcoholism. Nope. So I got adenocarcinoma is the right answer. So we have GERDs causing Barrett's esophagus, which is metaplasia. That can cause dysplasia. The dysplasia leads to adenocarcinoma. Yep, makes sense.
So again, in the picture, you said we saw a squamous epithelium change to a, what type was it?
That's supposed to be esophagus. That should be a squamous epithelium.
Right.
Should be stratified squamous epithelium, but instead you see columnar cells with goblet cells. That's not supposed to be there. That's the metaplastic epithelium, and that's caused by the GERDs.
Turn on the AC.
It's like, I'm trying to interpret the silence. I don't know quite how to do it. Like being stunned, or yes, we get it, or.
It, yeah, it makes sense. It's just.
All right. I think that's it for today then.
All righty, thank you.